Laparoscopic myomectomy. Laparoscopic myomectomy depends mainly on three advanced surgical skills, and today we will break down these skills in a simple way. Hello everyone, I am Dr. Reyam, and today we are discussing the surgical techniques for doing laparoscopic myomectomy. These skills are Myoma Enucleation, second, suturing the myoma bed, and lastly, specimen extraction. So let's start with the first technique. To do myoma enucleation, an incision is made over the uterine wall. The direction of incision, whether transverse or longitudinal, depends mainly on the suturing approach and the port position. If you are working ipsilateral or contralateral, a transverse incision is easier for suturing. But if you are suturing through a midline port, a longitudinal incision may be more ergonomic. The incision is made through cold scissor, harmonic scalpel, or monopolar hook. One of the most important surgical principles is identifying the correct dissection plane to minimize blood loss. It is usually better to slightly deeper into the fibroid and then identify the dissectable plane rather than making a superficial incision. Then myoma is grasped using a tenaculum forceps or myoma screw, and traction is applied. At the same time, countertraction is performed using a grasping forceps or section irrigation nozzle. There are some tips in the dissection. First, when a fibrous band are encountered, use a sharp dissection. Second, keep the grasp close to the dissecting point and push the myometrial edge away. Then, keep the dissection evenly in all directions. And lastly, be careful near the base to avoid entering the endometrial cavity. Once the fibroid is removed, proper closure of myometrial bed is critical to restore the uterine integrity and to prevent hematoma formation. A commonly used suture is Vicryl number 1. Its length is around 30 centimeters because short suture may require multiple replacement and long sutures become difficult to manipulate. And the needle should enter the tissue at 90 degrees. Multilayer suturing is required. Continuous or interrupted technique can be used. And for serosal, baseball suture technique is used. The final challenge is safe myoma extraction. If multiple small fibroids are present, pass suture through them to create a bead-like chain. Then, a posterior colpotomy is created 1 to 2 centimeters below the cervix. After that, expose the vagina using one retractor to elevate the anterior vaginal wall and other to retract the posterior vaginal wall. Then, pull the suture through the vagina, but in case of large fibroid, reshape the fibroid first. Another technique is manual morcellation. The fibroid is sliced in parallel cuts to create an accordion-like shape. How to do this? The center of fibroid is inside, followed by multiple parallel cuts without completely transecting the specimen. But there are important precautions during manual morcellation. First, firmly grasp the fibroid. Second, the scalpel must be controlled. Then keep cutting under vision. And lastly, the cutting edge should be upward. So if you found this video helpful, don't forget to like, share, and subscribe. Thank you for watching and see you in the next video.